Next presenter, we have Dr. Grace Bassey. So we request Dr. Bassey will be presenting on the topic clinical diagnosis of malaria infection in under 5 years old children. So this is the topic she'll be presenting on. Over to you.
Okay, thank you very much. Good morning, all. Like you said earlier, I want to thank Texila for granting me this opportunity to present my topic and to be a presenter in the Texila American University. Thank you very much. My topic is on clinical diagnosis of malaria infection in under 5 years old of age. Okay, so these are my outline because of our time. Because of our time, I may not really go through it, but you can see it. Introduction, we're talking about introduction, clinical features, parasitological diagnosis, RODT, and microscopy, and so on. I've displayed it on the screen because of our time, please. Thank you very much. So, introduction. Okay, so introduction, integrating AI into artificial intelligence into pediatric health care, and then enhancing early detection of malaria in under 5s. And malaria is as we may know, is a life-threatening disease caused by Plasmodium parasites. So, and it is being transmitted through the bite of an infected female Anopheles mosquito, and it has to be infected female Anopheles mosquito. And then children under 5 years of age are most vulnerable to severe malaria due to their underdeveloped immune system. Then we have 5 species of Plasmodium. We have Plasmodium malaria, Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium noense, as you've seen. It is preventable, and they're all preventable and curable. So WHO region carries a disappropriately high share of global malaria burden. And then in 2017, the region was home to 92% of malaria cases and 93% of malaria deaths. Okay, so introduction continues. So populations has considerably high risk of getting malaria. I don't know what is covered. Okay, so like I said earlier, populations at considerably high risk of getting malaria and developing a severe disease are, well, children under 5 years of age, pregnant women, people living with HIV/AIDS, and then non-immune immigrants, and then migrants, and mobile population travelers. And then sleeping under LI net, that's a long-lasting insecticidal net, for the last 2 weeks was found to be protective against mosquito bites. And then this is because water collection is one of the favorite conditions for mosquito breeding, which in turn, then staying outside during the night, showing a statistically a significant association with malaria, and staying outside during the night increases the probability of mosquito bites due to the nocturnal nature of the mosquito. Briefly on clinical features. Clinical diagnosis of malaria in children under 5 years of age is challenging due to non-specific symptoms, which may resemble other childhood illnesses. Common symptoms include fever, and that is temperature greater than 38 degrees centigrade, and then chills, vomiting, diarrhea, abdominal pain, cough, weakness, refusal to feed. When a child is not feeding, we have to find out what it is, so, well, it may be because the child does not like the food, and also malaria can be the cause of it. So I want to also talk about parasitological diagnosis. Prompt and accurate diagnosis is part of effective disease management. Like I said earlier, the child doesn't have appetite. We don't know why. That is why the testing is very, very important. And then changing epidemiology of malaria due to scale up of interventions have also increased the urgency of improving the specificity of malaria diagnosis. Prompt pathological confirmation by microscopy or a rapid diagnostic test is recommended at all or in all patients suspected of malaria before treatment is initiated. You see, some people may assume that, oh, my test board has changed, I have joint pains and so on, and then maybe a little fever and so on, and then because of that, they start the treatment. No, it's important, to carry a laboratory testing before commencing treatment. So treatment solely on the basis of clinical suspicion should only be considered in children less than 5 years when a parasitological diagnosis is not accessible. And improve patient care in parasite-positive patients, advocation of parasite-negative patients in whom another diagnosis must be sought. If it is negative, other diagnosis must be sought immediately. We must not assume before commencement of treatment. Prevention of unnecessary use of anti-malarials, reduction of frequency of adverse effects, especially in those who do not need the medicines, and reduce pressure of selecting new drug for resistant parasites. And also improve malaria case detection and reporting is very, very crucial. And treatment monitoring and follow-up to confirm treatment failure successes. Why am I saying this? Because sometimes you see that the drugs are different. The drugs may not be working. It's not because the malaria is not there. Maybe it's as a result of the drug faking and so on. So I want to also talk about rapid diagnostic test and microscopy. Parallel testing with microscopy and RDT is not recommended. We have to also use WHO standard. You start with the rapid diagnostic testing before you go on to microscopy. If maybe it is positive and you want to know the magnitude of it or quantify it, then we can go ahead to do microscopy. You don't do RDT alongside with a microscopy at the same time. You do them differently. And then the choice between RDTs and microscopy depends on local circumstances, including the skills available, patient case loading, epidemiology of malaria, and then what are the advantages of microscopy? Microscopy can be used for quantification of parasite, like as I said earlier, and also it can also assess response to anti-malaria treatment. If it is not working, the doctor may decide to change, or maybe start with polluter and so on, and also can detect other causes of fever. So in my, I've shown a chart here on how to carry out the rapid diagnostic testing. This is the step one of it. So if you go through these steps, it tells us on what to do, and it is very important. Some people may feel they know how to do it. It's not just get set and so on. No, because if you look at the slip inside the SOP, it states the timing and so on. And if the right procedure is not being followed and the negative result is obtained, and then at the end, we feel that, oh, the child does not have malaria, or maybe the control line may not show, but the testing line may show, and that is an invalid result. It is not recognized. So the next slide. So this is also the slide, the cassette showing the rapid diagnostic testing. From here, we can see there is also the well for the blood, and there's a well for the buffer, and also the window for the testing window. And if after applying the blood and then the buffer, and you see that there is nothing on the control line, then the test is regarded as invalid, and you may have to repeat the test. Then we go over to, I also want to classify a classification of clinical malaria. How do we classify malaria this time around. It can be classified into two: uncomplicated malaria, or we also have severe malaria. When it comes with signs and symptoms of malaria, illness that are not life-threatening, though, can proceed to life-threatening if not treated immediately. For this uncomplicated, I'll also show us a diagram, showing all this. Seeing that maybe there is cough, there is a little catarrh or things like that. It is very, very important, because you still have to take note of it and go to do laboratory testing, because, well, this may not be life-threatening, but it is still good to take note of it. And then for severe malaria, when the signs and symptoms are accompanied by one or more life-threatening signs, usually referred to as danger signs, this is dangerous, and the patient must be referred to the health facility immediately. So also now I've told us about the uncomplicated malaria. This is the table showing. You can see from that first one, we have the child, is having chills and a little fever. And in this case, sometimes you may go to the laboratory to do the testing, and then by the time they do the rapid testing and nothing, you feel the child does not have malaria. No, if the cycle of mosquito is not completed, it cannot be seen in the blood. It's just like carrying out pregnancy test. If it is not up to 14 days after the LMP, it cannot be positive, with urine, except maybe you use a plasma or serum. And then we also see headache and body ache, body ache. The child has headache, is complaining of headache, and he's touching, the child may not be able to talk, but he's touching the head and he's beating the head. And then also the child is not eating. You are feeding, he's not eating. The child is also vomiting. So that is why it is important to go for laboratory testing. Then we also have the features of severe malaria. Like you can see, this, assuming that this is a physical body of man, and then you can see from the brain, you see impaired consciousness, multiple convulsions and coma. That is in severe malaria. When the child keeps convulsing and so on, it is very important to rush the child to the health center. And also you have jaundice. You look at the eye coloration, it has changed, inability to eat, no appetite, and then even respiratory distress, it's not breathing well, and then circulatory collapses, the system is stopping gradually. Extreme weakness, the child is weak, is unable to stand, and even sit. And also you have hemoglobinuria, and you see the child is urinating and you are seeing blood in the urine. And also you see decreased urine output. Is very, very important to rush the child. When you see all these severe signs, you rush the child to the nearest health center. And then we also have, malaria parasite sentinel surveillance. In the sentinel surveillance, National Malaria Elimination Program established, malaria parasite sentinel surveillance and the sites in all the 36 states of the Federation and in Federal Capital Territory, FCT. So the sites were designed. Why was this site, established? They were actually designed to be a network of health institutions that will continuously and systematically collect daily information from the laboratory on severe cases and follow up for all confirmed malaria cases. And also it was also cited why the aim also was to complement the health management information system, reporting system, with additional information required for policy decisions. Example, parasite density, parasite species, and treatment failures, etc. And one medical scientist and a medical doctor serving in the facilities were selected to be the focal point of the surveillance system. So I want to talk about also the diagnostic criteria. What were the criteria that were stated by World Health Organization? The WHO recommends the following diagnostic criteria for malaria in children under 5 years of age. Fever, auxiliary temperature greater or less than 37.5 degrees centigrade, that's one. Then parasitological presence or confirmation, that is presence of Plasmodium parasites in blood detection through, like I said earlier, microscopy. And how do we do it? You make a smear on the slide and you stain by a thick blood film or a thin blood film. Some people prefer to use Giemsa stain or field stain. You know, or you can also use Leishman stain, you know, and that is Aru, or also RUDT. So exclusion of other causes is to rule out other conditions with similar symptoms such as pneumonia, meningitis, or sepsis, or even typhoid, because in typhoid too, there will be abdominal pains and there will also be vomiting and also lack of appetite. So I want to also briefly talk about the therapeutic efficacy study, TS. This is the treatment of symptomatic patients infected only with Plasmodium falciparum with a standard dose of an anti-malaria drug and subsequent follow-up of parasitemia and clinical signs and symptoms over a defined period. WHO currently recommends monitoring the efficacy of first and second lines of ACTs every 2 to 3 years in all falciparum endemic countries to identify the number one, the proportion of patients who are parasitemic on day 3, and then number 2, the indicator of choice for routine monitoring to identify suspected artemisinin resistance in Plasmodium falciparum. The proportion also of treatment failure by 28 days of 42-day failure, that's depending on the partner drug half-life in the specific ACT. The country currently has 7 TS. The first one is Enugu, Plateau, Kano, Adamawa, Lagos, and also Cross River and Sokoto State. Since their adoption in 2005, all the recommended ACTs in the country were found to be efficacious in the TS carried out in 2009/2010 and 2014/2015. The 2018 and 2019 TS was seen to have been ongoing as it is then. So I want to briefly talk about the limitations of the research. What were the limitations? As a limitation of this research, since it is a cross-sectional research, it only captures the point prevalence and cannot account for seasonal trends in transmission. All surveys are self-report with no confirmation of bed net ownership of use, and also RODTS with a PCR confirmed were not conducted, nor are there details on the life stages of detected parasites observed, gametocytemia and parasitemia. And then clinical, what were the challenges? I will rush over the challenges. The challenges. What were the challenges? Yes, challenge. Let's talk to them. Sorry, please bear with me. The challenges. So what were the challenges in the diagnosis? Co-infections with other diseases, like I said earlier, typhoid and so on, pneumonia and so on. The limited access to diagnostic tools in resource-poor settings, difficulty in obtaining blood samples from young children, relatively low level of testing, and then access to appropriate treatment with patients in rural areas disadvantaged, inadequate trained human resources for case management, weak referral systems militating on quality of care for severe malaria, and poor pharmacovigilance and irregular monitoring of efficacy of malaria medicines and non-functional malaria sentinel sites. Continued use of non-recommended malaria medicines in malaria treatments, perhaps when they feel that, okay, they stop, they discontinue with the treatment. Low uptake IPT, the intermittent preventive treatment for also pregnant women, and low utilization of antenatal services, persisting reports of stockouts of RODTS and ACTS, and over dependence on donor funds, which, instead of being dependent, failure to sustain the supply of affordable quality assured ACTS, and delay in scaling up key interventions. So in conclusion, bear with me, I don't know where my slide is. Okay, so in conclusion, the most significant symptoms of malaria infection among children under 5 years include headaches, chills, fever, nausea, body aches, vomiting, and sweating, coupled with general body fatigue. The above symptoms may at times be misdiagnosed as other infections. The prevalence or maybe incompetent hands, sometimes they just write malaria parasite in or no malaria parasite in, whereas there is malaria parasite during microscopy. So the prevalence of malaria in under 5 children attending healthcare facilities in, for example, Bulgaria district was high. Regularly sleeping under a bed net, stay outside during the night, and stagnant water around the household were the main correlates of malaria. Also bushes around not cleared, and focusing on dustbin, waste bins littered around, and focusing on LIN distribution, environmental management, and changing attitudes towards malaria prevention and control through health education would help minimize the burden of malaria. And also, early diagnosis, therefore, and treatment are crucial to prevent severe malaria and reduce mortality in children under 5 years of age. And also, healthcare providers should be aware of non-specific symptoms and diagnostic challenges, and use a combination of clinical evaluations, parasitological confirmation, and exclusion of other causes to make an accurate diagnosis. Conclusion continues. Yes, so of also the same area of 585 children who provided blood samples, 51, that is 8.7%, had malaria in some healthcare facilities in Ethiopia. And the predominant Plasmodium species were Plasmodium falciparum, that is 33 and 65%, and P. vivax, prevalence of 18 and then 35%. So regularly sleeping under long-lasting insecticide-treated nets, was associated with decreased odds of malaria. And then those are the findings. And then increased odds of malaria was also observed amongst children who live in households with stagnant water in the compound. And also those are the values also, and children who stay outdoors during the night. So what are the recommendations? Number 1, improve access to diagnostic tools, especially RODTs must always be made available, and enhance healthcare provider training on malaria diagnosis and management. And it is also important to have SOP, and then the job aids well written out and pasted, and also the leaflet that comes with the RODT must be read, because different manufacturers may have their own setups or write-ups and so on. And promote integrated management of childhood illnesses strategies, and also encourage community-based malaria control and prevention programs, and continued public health interventions targeting proper utilization of bed nets, drainage of stagnant water, and improve public awareness about reducing the risk of insect bites, as this will enhance the potential to minimize the mosquito bites. So these are the few references I cited, from my findings. And then thank you very much for listening, and God bless you. Thank you so much.
Thank you, Ms. Gracie, for a wonderful presentation. Now we move on to the Q&A. So participants can post your queries or questions, doubts in the chat box, and Ms. Grace will be answering them. Ms. Grace, there is a question in the chat box. I'll read it for you. Was there any estimate if the occurrence of malaria reduced after your intervention and recommendations in the area? What impact was seen?
So the impact. Actually, yes, of course. When after administering the ACTs and so on, before that is after doing the testing, laboratory testings, and then administering the ACTs, there was great impact, and the malaria infection was reduced. The rate of infections was reduced. Thank you.
One more question is there. Is
Okay,
there a possibility that one may have the same symptoms for some other disease?
Yes, it is quite possible. One may have malaria and have typhoid at the same time. So that is why it is always very important to do laboratory testing. And in fact, by the time you do the slide, you do RODTS and it shows no malaria parasite, well, it is still good to go ahead and do, or maybe, yes, you go ahead and do the microscopy. Microscopy will give a better view. And also, because like headaches, you may have headaches, fever, chills, and the rest of and vomiting. Typhoid can also cause a vomiting. That is why testing is very important. And most of the doctors, will ask the baby to, okay, like I said earlier, other symptoms may be there. For example, typhoid. That is why it's very important to run this test. And while doing the malaria microscopy on the slides too, you may see also other sick illnesses. And in the full blood count will give a full picture of what is happening. It will give you an indication. For example, if you do the differential count, and the differential count consists of for example, neutrophils, lymphocytes, and the rest of them, okay? Monocyte, eosinophils. And if there is also allergic reactions causing the headaches and causing maybe rashes and so on, it will also be revealed through the full blood count. And also, for example, in the red blood cells is pneumochromic and so on, monocytic, it also reveals other illnesses. So apart from that, other symptoms may come up. That is why full blood count is very important. And the doctors, they normally ask for, malaria parasite test, full blood count, and maybe MP-Widal, and maybe packed cell volume, PCV, to know maybe the blood level has really gone down as a result of the illness. Thank you.
Doctor, one last question. Is there any research done on malaria vaccine?
Yes, actually, yes, people keep saying that malaria vaccine is good, but I still feel that even if you take the malaria vaccine and you expose yourself, you don't use the LLI net, then in fact there is a problem, or you expose yourself, or maybe your surroundings, there are bushes, there are stagnant water, the gutters are not being cleared, and so on. It will still, it will still not help. So the best thing is, diagnosis and then the treatment. Thank you.
Thank you, Dr. Grace.
My study area is in Abuja. Sorry, my study area was in Abuja, FCT, Federal Capital Territory, precisely Federal Staff Hospitals. Thank you.
Thank you, Dr. Grace, for a wonderful presentation and for taking up and answering the questions.